Good afternoon. My name is Dr. Monzon. I'm the head of trauma surgery at the Steve Biko Academic Hospital, and I want to thank you for the opportunity to share some of my experiences with you. This talk is related to advanced trauma life support and is divided into two parts. First part will talk about the principles of ATLS. Part two will talk about specific injuries and how to identify them. What is ATLS? It's a system designed to identify the common causes of mortality in trauma patients. The intention is to establish priorities of treatments, meaning you treat the things that is more important or the one that is going to kill your patient first. The ATLS is divided into primary survey, resuscitation, secondary survey, definitive treatment plan, and the disposition of the patient. Why trauma patients die? There are three waves of mortality. There is an immediate peak of mortality that occurs in the scene of the incident, which is usually secondary to airway obstruction, massive hemorrhage, and devastating head trauma. These deaths are usually non-preventable because they all depend on the quality of the trauma system that is in place in that particular region. Then there is another two waves of mortality, the early mortality that occurs within the first 24 hours, usually related to recognition of life-threatening injuries, presence of uncontrolled hemorrhage and traumatic brain injury, and sometimes delays in the instituting the life-saving treatment that the patient requires. And the late wave is secondary to infection, complications of injury and surgery, and they are usually preventable because if the appropriate treatment is initiated, there should not be any issues. The primary survey intention is to determine or identify life-threatening injuries and initiate a treatment for this. What are the life-threatening injuries? Airway obstruction, tension pneumo, open hemothorax, massive hemothorax, and cardiac tamponade. The diagnosis of this condition is clinical, and the interventions necessary to resolve are usually within the scope of GPs, being intubation, inserting a chest drain, or suturing a wound. The secondary survey then should identify injuries that may require surgery or could result in complications and death. And after all of that is completed, then consultation with the appropriate specialist for the further care of the patient should be required. The resuscitation involves stopping external hemorrhage, the use of intravenous fluid, and the new ATLS recommendation is to use a maximum of 1 liter of Ringer's lactate instead of 2 or more. Initiation of emergency blood transfusions in patients who are in shock, and then deciding who needs surgery and when is that surgery going to be done, or whether the patient needs to be investigated. The adjuncts are the EFAS, or extended focus assessment by sonography in trauma, obtaining chest X-ray, pelvis X-ray, CT scan when indicated, inserting a nasogastric or orogastric tube on the patient, inserting a Foley's catheter, giving the patient a single dose of prophylactic antibiotics, giving tetanus prophylaxis, and then using monitoring, including arterial blood gas and coagulation monitoring. In summary, the ATLS is a simple system that is designed to establish priorities of treatment. The approach is systematic to avoid missing injuries. It must progress from A to B to C to D and to E finally. And this station should not be jumped over unless there is an obvious problem. In the case, for example, the patient comes with a massive external hemorrhage, you should stop that hemorrhage before deciding to intubate the patient or anything else on the patient. Then you need to decide who needs surgery and who can be investigated, and if the patient needs surgery, where is that surgery going to happen, in your local hospital, or do you need to transfer your patient? Thank you. Welcome. Part 2 of our talk regarding ATLS revolves around the identification of injuries or the life-threatening injuries. So we're going to divide them into a simple understanding of what the problems are. The first problem that we need to identify is airway obstruction. The clinical signs of airway obstruction is the inability of the patient to move air, and this is clinically expressed by inability to speak. Sometimes there is stridor, and sometimes the patient is unconscious and is unable to breathe by himself. There are several treatment options that you can exercise. In practical terms, you should open the mouth of the patient, suction the mouth, remove any foreign bodies, blood, mucus. There are some simple techniques like jaw thrust and chin lift that can be done to open up the airway of the patient. Supplemental oxygen should be given to every single patient, particularly those who have a threatened airway. And then you should consider when to intubate your patient and whether to create a surgical airway. Intubating the patient using a rapid sequence induction or a drug-assisted intubation, as it's called these days, is the definitive treatment for a patient with an airway obstruction. Tension pneumothorax is a catastrophic injury involving the respiratory system. It's characterized by respiratory distress, a patient that is speaking in very short sentences. He shows air hunger. Those patients are hypotensive. They will be absent air entry on the affected side with tracheal deviation to the normal side. The percussion of the chest will be hyperresonant, and occasionally you will see distended neck veins with a lot of surgical emphysema on the chest wall. The treatment is to provide oxygen to the patient, do a needle or a finger decompression on the fifth intercostal space anterior to the mid-axillary line, and then insert an intercostal drain, which is the definitive treatment. It's important not to try to intubate these patients because intubating and providing positive pressure ventilation will worsen the tension pneumothorax. An open pneumothorax is a very simple thing to diagnose. It's usually associated to a penetrating injury where there is a laceration on the chest wall that is larger than the trachea. Usually a 3 centimeter or more laceration will start bubbling air and blood via the chest wound, and because of normal physics and the distribution of negative pressure in the chest, the patient will breathe preferentially through the chest wound rather than to the trachea. They will be severely hypoxic, and in some instances, the patient will be in hemorrhagic shock depending on the associated injuries. The treatment is to give oxygen, apply a 3-sided dressing, which is a simple piece of plastic with tapes on 3 sides, leaving one side untaped, that allows the air to escape the pleural cavity and prevent a tension pneumothorax. The definitive treatment consists of inserting an intercostal drain in theater or in the emergency department away from the wound, and then operating on the patient to debride that wound and suture the chest wall close. A massive hemothorax is also a life-threatening injury, usually occurs after penetrating injuries, but a blunt trauma can also do it. These patients will present in hemorrhagic shock with a classical intercostal drainage of more than 1,500 mils of blood or more, or a persistent 250 to 300 milliliters of blood of output in 6 hours. They will be hypoxic, hypotensive, showing all the classical characteristics of hypovolemic shock, and they will require immediate surgery. The treatment is to secure the airway by intubating, starting emergency blood transfusion, refers to surgery for an emergency thoracotomy. But please don't forget that these patients, the blood that is being drained from the chest can be used for autotransfusion. And one thing that we always tell is please do not clamp the chest tube. The hemorrhage will continue inside. Remember that the lung circulation is a low pressure system, and there will be no tamponade because the mediastinum can displace significantly to the contralateral side. Cardiac tamponade is usually involved in injury to what is described as the cardiac box. It could be penetrating, which are the more common ones, but blancas also can cause tamponade. This patient will be in shock, and this is not hypovolemic usually, it's a compressive type of shock. They will be hypoxic, they may have a left hemothorax, and a large pericardial effusion will be seen on the EFAST. The classical description of the Beck's triad with hypotension, distended neck veins, and muffled heart sounds are not commonly seen. The most common presentation is a patient with a penetrating injury who has hypotension. The treatment is to intubate. Patient may be needed an adrenaline infusion and a blood transfusion, and they need to be immediately transferred to the operating room for a thoracotomy. And that concludes our talk on ATLS. I'm waiting your comments and questions. Thank you.